I'm Jackie Gambrell, General Manager of TSA. Today I'm joined by Dr. Sean Kennedy, a nephrologist with Sydney Children's Hospital in Randwick and the School of Women's and Children's Health at the University of New South Wales. Sean is also one of TSA's medical advisors. Sean joins me today to discuss the current management of kidney tumours associated with TSC, including the diagnosis, surveillance and treatment options. So, Sean, thanks so much for joining us today. What are the most common kidney symptoms of TSC?
Thanks, Jackie. It's a pleasure to be here. With TSC, the most common features in the kidneys are something called AMLs or angiomyolipomas. These are tumours. Now, when we talk about tumours in medicine, we sort of divide them up two ways, like malignant tumours, and that means a cancer. And cancers can spread and metastasize into other places. And we talk about benign tumours, which are really just lumps that can grow, but they usually don't spread and don't cause the same problems that cancers do. AMLs are benign tumours, so they're not a cancer, they're not a malignancy, but they certainly can grow. What they are start off as little lumps in the kidneys, and they're a little collection of cells which grow into be something that's not usually in the kidneys, and that's in particular a bit of fat and of some blood vessels. The word angiomyolipoma, AML, tells us what's usually in these little lumps. So angio means blood vessels, myo means muscle cells, and lipoma means fat. And so these are little fatty lumps that have little abnormal blood vessels in there. Now, if they're only tiny, which they are for most people who have TSC, they don't cause problems. It's just as they get bigger, because of the little blood vessels can get bigger themselves, and they're not really well-formed blood vessels, so they can have weak walls, and that means that they can leak, they can burst the blood vessel within the lump. And that's the main problem we see with AMLs, which is bleeding, and it's bleeding into the kidney, which if you have TSC and you have a bleeding AML, you would know because you may have pain in your back, pain in your kidney, or blood in your urine. So your urine, your wee turns red. That's very rare. So as I said, most people with TSC have AMLs, but most people with TSC don't have problems from AMLs. And the problem, this bleeding, really only occurs when they get large. And by large, we mean more than 3 centimetres. And most children certainly, and a lot of adults who have AMLs, they're less than 3 centimetres in size. That's not to say that every AML that's over 3 centimetres will cause problems, will bleed. In fact, still most of them don't. And in our clinic, I see sometimes patients, more adults, who have AMLs that we've picked up on ultrasounds that might be 6 centimetres, 7 centimetres, sometimes 10 centimetres, and they've never caused problems. And actually, you wouldn't even know they were there, except that we did the ultrasound. So they don't bleed if they're less than 3 centimetres, but if they are more than 3 centimetres, it doesn't mean that they will bleed, but there is a risk of it. So that's the most common problem that you see in the kidneys if you have tuberous sclerosis. The other thing that we frequently see are cysts in the kidneys. Cysts are tiny little bubbles. They're just little fluid-filled bubble in the kidney. So you can see it easily on an ultrasound. And again, most people, a lot of people with TSC will have some cysts in the kidneys, particularly children. We see it early on in little kids when we're doing scans, and we might see some tiny cysts. They're not a problem. They're just there. They're just telling us that the TSC has affected the kidneys, but they don't cause problems. They don't cause pain. They don't cause infections. They don't rupture. They're not a tumour. And in fact, usually as people get older, it becomes harder to see those cysts. A small number of people who have TSC and they have the mutation in the TSC2 gene, that's a gene on a chromosome that sits right next to another gene that's a gene called PKD. PKD means polycystic kidney disease. And there are some people with TS who have a mutation in TSC2, and also the mutation moves along the chromosome and affects this PKD, this polycystic kidney disease. You can tell that because on ultrasound with those people, usually from a young age, you'll see big cysts, not the little cysts that we see in other people, but really big cysts. And they can, on their own, don't cause a problem, but it can be that those people who have that mutation affecting TSC2 and PKD can have ongoing problems with high blood pressure, and even as they get into adulthood can sometimes develop kidney failure. It's very unfortunate for that group of patients, but it's fortunate that they're very infrequent. That most people with TSC don't have that combined mutation. There's one other thing that we worry about with kidneys and TSC. When I say worry, it's not like we worry intensely for all our patients, but it's we look for, and it's why one of the reasons we see you if you have TSC regularly and do imaging of your kidneys is that we know that people who have TSC have a slightly higher risk of developing cancers in their kidneys. As I said, AMLs are not a cancer, but anyone can get a cancer in the kidneys, and we see it in adults. And if you look at all Australian adults, it's a fairly uncommon cancer, and it might be about 1% of the population can get a kidney cancer. And that's called a renal cell carcinoma, so RCC. That's in anyone, someone who doesn't have TSC. From what we can see from what's been written, published about TSC and in our own experiences here in Australia, if you have TSC, you have a slightly higher risk of developing those renal cell carcinomas, those renal kidney cancers. But it's only still that maybe 2% or 4% at the most. So it's still very uncommon. And the good thing is that if you have TSC and you're seeing a clinic or a doctor who's monitoring your kidneys, they'll be doing scans, ultrasounds, or MRIs or CT scans regularly, and they'll pick up a cancer early, and then it can be treated before it causes the sort of problems we think about with cancer. So it's worth knowing about that there's that slightly higher risk, but it's certainly nothing to worry about. And that's the main kidney lumps and bumps and bubbles that you get, Jackie.
Thank you. So it sounds like surveillance is really important. What are the main means of surveillance, particularly with children?
Yeah. So an ultrasound, so kidney ultrasound or renal ultrasound, is simple to do. And except for the kids who've got really severe behavioural problems, from birth we can do ultrasounds. And of course, if you've been pregnant, you've had plenty of ultrasounds when you're pregnant. And we can even see the baby's kidneys at that stage. So an ultrasound's easy to do. We can do it in children. We can do it in adults. You can get it just about anywhere in Australia. And there's no side effects of it. It's safe and simple procedure. If you're doing an ultrasound of the kidneys in a young child, sort of under the age of 2, it's probably better to get it done at a centre or a hospital which is used to doing children, because the kidneys can look a little bit different, and it just helps to have that experience. And those ultrasounds will pick up most of these kidney problems that we've spoken about, the AMLs and the cysts. They can miss some AMLs because, as I said, the L in AML stands for lipid or lipoma or fat. And you can see that easily on an ultrasound. It looks bright or white, but not all AMLs have a lot of fat in them. So there are some that don't have very much fat, and they can be difficult to see on ultrasound. So that's why the international guidelines recommend that also patients, children, adults with TSC have MRIs of their kidneys. The problem with that in Australia is that MRI for kidneys isn't usually covered by Medicare. If for young children, you have to lie still for 20 minutes sometimes. And if you've had an MRI, if you've got a child that's had an MRI, you know it's a great big machine that can be a bit scary and it makes a lot of noise. So it's really difficult for young children to lie still, which means for our children who are having MRIs, we usually have a general anaesthetic, so to be put to sleep so that they can have it. So there's more involved, there's more risks involved because of the anaesthetic. Now, for that reason, we don't, in Australia, push to have all of our TSC patients get their regular kidney MRIs. And we're happy with an ultrasound in most cases. But it's good to get an MRI occasionally. So it's worth talking to your kidney doctor to see if you should have an MRI or your child should have an MRI. And what we can do at the children's hospitals often is when the child's having an MRI for their brain, which, as you know, if you've got a child who's got a TSC, to look for the brain problems, they'll usually have MRIs. So they'll have a general anaesthetic for that. So if you talk to your doctors and if they talk to their hospital, they might be able to do it so that they, at the same time they're doing the brain MRI, they can do a kidney MRI. So that's what we try to do at Sydney Children's Hospital. Other ways you can take pictures of the kidneys, the other main one is a CT or a CAT scan. And a CAT scan is good. It will show you AMLs and it will show you AMLs that don't have much fat in them. It can be done quicker and not quite as scary as an MRI. So you may not need an anaesthetic, depends on how old you are or what your behaviour's like. The main downside for a CAT scan is that it's got radiation involved. So ultrasounds and MRIs don't include radiation. So CAT scan's good to do if you need to do it, good to do sometimes, but it's not something that you want to do every year because you end up having a lot of exposure to radiation.
Thank you. And look, people who do have TSC-associated AMLs, what are the treatment options that are available and how have those changed in recent times?
Yeah, that's been the most exciting thing for me as a kidney doctor who's involved with people with TSC is that we actually can offer you treatments now. And we always could, but they're better now. As I said, you don't run into problems if they're small, and it's only as they're getting larger, more than 3-4 centimetres, that you have that risk of bleeding. From the trials that have been done in the last 10 years and the trials that we've done in patients with TSC and AMLs, patients with TSC and brain tumours, the SIGAs, patients with TSC and the lung involvement, LAM, and more recently TSC and epilepsy. Of course, we found that class of drugs that you might have heard of, the mTOR, TOR inhibitors, as being useful in all of these aspects of TSC. mTOR stands for target of rapamycin, and the M stands for mammalian, as we're all mammals. And rapamycin you might have heard of because that's another name for one of the drugs that we use, and that's sirolimus. So there's a drug called sirolimus or rapamune, and there's another drug called everolimus. And as they sound similar, they are really similar as drug classes, just a minor sort of chemical change, but they have very similar effects. The brand name of everolimus in Australia is mostly used as Afinitor. And so patients with TSC might be on Afinitor for brain tumours, for the SIGAs, might be on Afinitor for epilepsy sometimes, but it's also been shown to help the kidneys, the AMLs. And what it does, it blocks the signals that are within the kidney that are telling the tumour to grow. So if you have a tumour that's 3-4 centimetres large and you take everolimus, over time, which usually means over, say, 6 months, you'll start to see an effect, the tumour will get smaller. It won't go away altogether. It'll get smaller while you're on the everolimus. So if you have a tumour that's 3 centimetres, 4 centimetres, 6 centimetres, and we're worried that it could bleed, then taking everolimus will shrink it to a size where it's less likely and very highly unlikely to bleed. So that's how we mainly use the drug now for kidneys. If you have large AMLs or your child has large AMLs in their kidneys, we can use everolimus to shrink them and reduce the risk of bleeding. Before we had everolimus, the main treatments for a large AML or an AML that was bleeding was surgical. So there was two ways. There's, as you think about surgery, going in and cutting out the tumour. And we can still do that if it's large or if it's been bleeding. But the problem is when you go into the kidneys to remove a part of the kidney, you take the tumour, but you also take good bits of the kidney. So the more you do that, you reduce your kidney function because you reduce the amount of kidney that's left. So we avoid doing that sort of kidney surgery unless there's no other options. The less invasive surgical type of procedure is called embolization, and that's done via a large artery. So if you've ever had, or your parents or grandparents or someone you know has ever had a coronary angiogram, someone who's got heart disease or had a heart attack, the cardiologists go in and look into their arteries in their heart by feeding a catheter, a tube, in through the artery in their groin, through the femoral artery, and then sort of feed it up to get to the heart and look at the blood vessels in the heart. We can do the same thing by the same way to look at the blood vessels in the kidney. So you can do an angiogram and just look at the kidneys. You don't have to go up to the heart. And then you can see if there's a AML there, because the reason it's bleeding is because it's those blood vessels coming off that are weak and might be leaking from. So you can go in with the catheter, find the AML, find those bleeding blood vessels and block it off there. So you can inject something into the blood vessel that blocks off the blood flow. So that means it'll stop bleeding or stop the risk of bleeding. And basically the tumour that's fed by that blood vessel will die. So it will shrink and then reduce your risk of bleeding. So that was what we used to do before we had everolimus. And we can still do it if you've got a really large tumour or if you've got a tumour that is bleeding now or has just recently bled. Again, the downside of it is obviously it's a procedure. There's some risk of bleeding from doing the operation and you can get some pain afterwards as the tumour shrinks. And also if you have to do it a lot of times, if you've got a lot of tumours or really big tumours, again, it can affect your kidney function because you can be blocking off the blood supply to good bits of the kidneys. So by far, for most patients with TSC, the best option if you've got large AMLs is to start the medication, start everolimus, and then you can hopefully avoid bleeding, you can avoid pain, and you can avoid embolization or surgery.
And how much do we know about the long-term effects of these medications?
Yep. In TSC, we are learning more all the time because mostly in the States, but also States, Europe, the United States, Europe and in Australia and other countries as well. We've been now using it in people who've got TSC for probably 10 years or more, and regularly sort of reporting and following up and talking to other doctors and researchers who are using it about the long-term side effects. And I'm pleased to say that we're not seeing a lot of long-term side effects. So it seems to be that if you're staying on these medications for a long time, it doesn't increase your risk of side effects. We also, before we used these drugs in tuberous sclerosis, we were using them in other things. We're using them in some cancers in adults, but in children and in adults, we're also using them in transplants with people who've got kidney transplants or sometimes lung transplants. And that group of people, again, we've got some long-term that they've been taking the drug for many, many years. So we can follow it up and see what the long-term effects are. So the long-term is not such a worry, but in the short term, though, there are side effects of it. The main couple of side effects, the first one is because we use it in transplant, the reason we use it in transplantation is that these drugs reduce your own immune system. Now, patients who have transplants, a kidney transplant, they might be on everolimus, but they'd also be on one or two other drugs that reduce their immune system. So they're a lot more immunosuppressed. than a person who's got TSC and is just taking the one drug. So that's worthwhile to think about. But if you are on the drug, then you do have more risk of getting infections because your immunity is a bit suppressed. It's mostly viral infections. Pleased to say that from what we've seen in the last 6 months or so, that it's not causing major problems with coronavirus, with COVID, that people who are taking everolimus haven't had major problems with coronavirus as far as we can see. But there is a risk. And so sometimes in children, we can see that if they've been on everolimus and they get sick with a virus, you know, they can get a little bit more sick. It can take a little longer to get over it. But it's not that we have to wrap them in Glad wrap or keep them in a bubble. It's just you've got to make sure that you've got all your immunisations up to date, the usual sort of hygiene to avoid infections, which we're becoming really good at the moment. And, you know, to see your doctor quickly if you're taking the medication and you get a fever or your child gets sick. The good thing about it also is that if you're taking it because of you've got these tumours in your kidney or even in your brain and you get sick with an infection, you can actually stop the drug until you get over the infection. Because if you've got a 3 centimetre tumour, you've been on everolimus for a year, it's shrunk down to 1.5 centimetres. If you stop everolimus for a month, it's not going to grow back in a hurry, it'll still stay small. So you can sort of stop and start if needed. The most common side effect that everolimus has, and anyone who's taken it has probably experienced it, is you get mouth ulcers. And it can be related to how high the dose is, but it's sort of, they can come and go. We see it, teenagers who've got braces and got other reasons to have sort of irritation in their mouth, they seem to get it worse. So it sort of like compounds the problems that they've already got. So that can be uncomfortable for people. There's different ways to treat it, just sort of oral hygiene, mouth washes, but even some some creams and ointments can help if you've got a bad outbreak of ulcers. And then there's, like every drug, there's a long list of other potential side effects. Most of them aren't severe or aren't common. You can get higher cholesterol if you're taking everolimus, and it's something to watch. But, you know, I won't go through all of the long list, but if you're on the medication or your child's going on the medication, talk to your doctor about it, work out how to monitor it. As I said, most of the side effects are worse if you're on a higher dose. But some people need a higher dose to get a good effect, but we can actually look at the effect by measuring the level of the drug in your blood. So you do a blood test and check the level of it, and that gives you a better idea than just the dose, but it's one way to monitor it. But in terms of long-term effects, you know, we're not seeing that there's a long-term effect on your immune system or ability to fight infections if you stop it. Not a long-term effect on developing other cancers. We had some concerns early on because it reduces growth of the tumours, whether it would affect the growth of children. And we're not really seeing that in a major way. I can't say, we've looked, and it's not like kids who take everolimus end up being shorter. One other effect that I think should be considered is that it can affect fertility, your ability to have children, have babies, particularly if you're a male, that it affects the development and the activity of your sperm for older males. So again, it's something to think about and talk to your doctor about if you're going to be on it long term and you're planning on having children in the long term. Seems to have less of effect in that respect for women, but some girls, young women who are on it can get irregular periods. But as far as we can see, it's not clearly reducing their risk of having children. But if you are, you can't have it while you're pregnant because it can affect your baby. So if you've got TSC and you're taking this drug and you want to fall pregnant, you should talk to your doctor about stopping everolimus and you know, while you're trying to get pregnant and while you're pregnant.
Thank you. Is there anything else our TSC community should know around these drugs or TSC-associated AMLs or any other kidney issues you think you want to highlight, Sean?
Thanks, Jackie. Look, I think importantly, we can do something. Don't worry about things. get a good relationship with your doctor, with your kidney specialist, your paediatrician, your adult kidney specialist, or a urologist, or the kidney surgeons, or the other doctors who look after these things. If if your doctor's found a lump, say your GP or someone's done a scan and they found a big lump in your kidney and they say, oh, we've got to cut that out, or we've got to do surgery on it, don't be afraid to ask for a second opinion, because it's still pretty rare and not every doctor is experienced with seeing TSC or using these drugs these days. So, you don't always feel that you need to go down the path of surgery and ask for a second opinion, and it might be talking to someone who's had more experience with TSC. Probably one other thing is, if you are having that embolization surgery, make sure your doctor gives you some medications before you have the procedure to reduce the pain, because occasionally I've seen patients get it and then have a lot of pain after because they haven't been given the right medicine beforehand. But hopefully you can avoid that if you use the medication. And don't be scared of the medication, even though if you look at the list of side effects and it'll turn you off, you think, oh, wow, there's way many side effects. But in fact, so many, you talk to other patients who are using it, and there are a lot of people who are having good results from it. And if you're getting side effects, or your child's getting side effects from it, again, talk to your doctor, because there might be ways to manage those side effects, maybe changing the dose, reducing the dose, or doing something else to reduce the risk of side effects. But yeah, I think the bottom line is, if you've got TSC, your kidneys generally will be involved. If you've got a child with TSC, it's highly unlikely that their kidneys will cause problems. But you just need to be monitored. We pick up problems early, we can manage them.
Thanks so much for that, Sean, and thanks for sharing your time and your expertise with us today.
Thanks, Jackie. Pleasure.